everyone. Welcome to Good evening, everyone. Welcome to the sixth session. We have the sixth postgraduate seminar on research ethics, and this is organized by the Director of Postgraduate Studies on behalf of the Ethics Review Committee. And I'm happy to see with us today Dushi, who is the new president of the Ethics Review Committee, and Kaushalya herself is the secretary of the Ethics Review Committee. And this is the Ethics Review Committee of the Humanities and Social Sciences of the Faculty of Arts. And we have a very interesting topic today. Just to set the background, let me remind you about the Nuremberg trials, which were conducted after the Second World War, which involved representatives from the United States, the Soviet Union, and France and Great Britain. And it was the first time a trial was held in history. And the defendants were faced with charges ranging from crimes against peace to crimes of war and to crimes against humanity. And what was most shocking in these trials was what came out about what was done in the name of science. And this was particularly highlighted as being crime against humanity because under the guise of science, there was a lot of research that was done in this period under the Nazis involving the Jewish population, where there was research done on issues such as nutrition, progression of diseases, pain, and twin studies, and all these were done in the name of science, but they involved the most horrendous crimes. And this was this resulted in what we call the Nuremberg Code, which was formulated straight after these trials, where it told researchers how they should set about doing research. So the Nuremberg Code actually stresses the need to carry out research while protecting the vulnerable groups, and in particular, it stresses the issue of captive populations, where it was very clear that the Jews who were under Nazi concentration camps really did not have any choice of whether they were going to be research participants. And here today also we are going to be focusing on this issue of captive populations, where the three speakers will be talking about different types of captive populations: patients, children with disabilities, and students. And I think this is very useful, the session for us, because particularly without being very conscious of it, we often involve people in our research who are, in a sense, captive populations, though we talk about trying to give it being voluntary research. Very often we think of something as voluntary research, but people have no right to actually volunteer out of it. There is often in developed countries where people get marks for being in a research, and therefore it seems very voluntary, but when you realize that the benefit they gain is marks, one realizes that they are actually a captive population. So to begin the formal sessions, let me invite Professor Sivasuriya Sivaganesh, who's a professor of surgery at the Department of Surgery, Faculty of Medicine, University of Colombo. And it's nice that we have people from across the different disciplines addressing this postgraduate population. And he has been a member of the Ethics Review Committee of the University of Colombo, in the sense of being in the Faculty of Medicine. He has been in that ERC. And he was a Commonwealth scholar who completed his PhD at the University of Cambridge. And he's a surgeon with an interest in, as he explained to, I was talking to him about the transplant surgery, and his interests range to hepatobiliary and pancreatic and transplant surgery, on which he has published numerous articles. And this year he has also published on surgery and COVID-19. So he has a lot of experience, both as a researcher and as an ethics research committee member. And therefore, I'm sure we'll be interested in hearing what he has to say. So it's over to you, Professor Sivaganesh. And we will then go on to the other speakers, and we'll take the questions at the end. So please, if you have any questions, note them down and keep. So thank you. And Professor Sivaganesh, the floor is yours.
Thank you, Prof Amala. I'll put my I've got a PowerPoint slide up, so I'll be able to share that.
You should be able to share it, yes.
Okay, so thank you. I first thank the faculty of the postgraduate. Thank you for inviting me for this seminar. I'm out of my usual comfort zone. I usually have meetings within our own group of medical professionals. It's a good experience. So thanks for inviting me. So I'll be talking to you all on a few aspects of ethics in medical research over the next 15 minutes or so. And briefly about some of the aspects of how we look through and the aspects we look at in assessing protocols, proposals that are submitted for ethics review in the medical field. So before going down to the actual aspects of research, medicine itself is, or it's said to be built on the pillars of medical ethics. And the 4 pillars of medical ethics that we talk about, because this is relevant in terms of research as well, autonomy, beneficence, non-maleficence, and justice. In very simple terms, what this means is we in beneficence act in the best interest of the patient. We seek as much as possible always to do no harm to patients. While these are towards the individual, it's also important when delivering healthcare to ensure that there is both equity and equality in its delivery. And finally, and this is again extremely pertinent and relevant to ethics in medicine, is the concept or the pillar of autonomy, which is a right to informed choice, whether be it research or therapy in medicine. Like Professor Amala de Silva stated, the fundamental, the Declaration of Helsinki by the World Medical Association World Medical Association Declaration of Helsinki in 1964 is the basis of research in medical ethics that we still follow. This, like she said, comes from the background of the Nuremberg trials, and the Nuremberg Code was sort of the predecessor to the Helsinki Declaration. And as you've said, it resulted from some of the horrific experimentation and crimes that came or was seen during World War II. But this was not just World War II, though. This is the background of the Nuremberg Code and the Nuremberg trials. Throughout the history of medicine, coming into the 20th century and even later, there have been numerous violations of the tenets of medical ethics. And so this was a predecessor of the World Medical Association Helsinki Declaration in '64. So the ethical principles for medical research involving human subjects from '64 to 2013, there have been about 7 revisions of the Helsinki Declaration. Having said that, yet there have been numerous breaches or violations of medical ethics even after the Helsinki Declaration, just to state a few. And in the US, these were some of the cases that showed how medical ethics can be forgotten. One was the Willowbrook State School, where mentally handicapped children were deliberately infected with the virus. The other one was where live cancer cells were given to inmates in a prison. Subsequently, this was repeated in Afro-American patients in the Jewish Chronic Disease Hospital. This was in the 60s, just before the Helsinki Declaration. And the person who did it, Chester M. Southern, said, well, I didn't wish to cause alarm in our patients, and therefore I didn't choose to mention that they were getting cancer cells. And the irony is he was subsequently also named the president of the American Cancer Society. So probably the most or the most notorious of this is, I'm sure some of you would be aware of this, is the Tuskegee syphilis study. This was done by the United States Public Health Service and the Center for Disease Control. It went for 40 long years, and what it involved was the subjects were, if I'm right, a few hundred African Americans who were observed over a period of 40 years without treatment to see what the manifestations of long-term syphilis would be. Mind you, by 1947 or 48, penicillin was available and known as the treatment for syphilis. And this went on right up to 1972. So it's probably the most infamous violations or breach of medical ethics, maybe in history or in the recent past. So coming back to the Helsinki Declaration, the fundamental tenet of this was, or is rather, the health of my patient will be the first consideration. And the physician will act in the best interests of a patient when providing medical care. If you look at the Helsinki Declaration, there are several sections. There are about 36 components to it. These are the broad areas in which with which they deal. One is, of course, there are some general principles. It looks at risks, burdens, and benefits to patients. There's a section on vulnerable groups and individuals. It talks about scientific requirements and research protocols. Research ethics committees are mentioned, how they are composed, and so on. Aspects on privacy, confidentiality, informed consent, the use of placebo, post-trial provisions, registration of research, publication, dissemination of results, and unproven interventions in clinics. So these are the major sections in the Helsinki Declaration. Now, I'll move on to our experience in the Ethics Review Committee of the Faculty of Medicine, Colombo. Now, almost all ethics committees in the medical sphere have their SOP or standard operating procedures and their protocols based on the Helsinki Declaration. So if you go through the protocols of these ethics review committees, they mirror the principles and the requirements that are laid down by the Helsinki Declaration. So I'll be going through those in a little more detail as we go along. So taking the Colombo Medical Faculty, ERC, it's one of those that are accredited by SIDSA, has a diverse membership, and all ethics committees should have a membership that is diverse. And by diversity, I mean there are medical, and even within the medical members, there are those who are from clinical, basic sciences, or who we call the paraclinical, and those with a background in community or public health. We have non-medical professionals from various institutions and also from the Faculty of Arts, Law, so professionals, and we have lay persons as well. I wonder, so the membership is diverse, true, but I'm not very sure whether that necessarily makes it representative. And when I say representative, I mean representative in terms of social representation. Whether what is actually reflected is a certain social strata of certain strata of society who's there. So that's something that is debatable. We have certain standard operating procedures, protocols. We meet on a monthly basis where we review proposals and decide on them. One aspect which is lacking or is still not done adequately is monitoring and reporting. So there is a fairly robust system to review proposals and make decisions. But what happens after that, the monitoring or the enforcement of that and reporting is something that can be improved and needs further, needs to be looked at further. So I think the gist of my talk today will be looking at what key aspects of the key important aspects of our protocol, or what we have a checklist. What do we look at when we get a research proposal? I think it's very important to start off by saying that we need to make sure that the investigators are appropriately qualified and have the experience required to conduct the study. Research studies, especially in medicine, of course, they are very heterogeneous, but should be done by those who are qualified to do it, especially since we are taking into account human subjects and their health. Another important aspect that we look at is conflict of interest. Are there commercial conflicts of interest, financial or intellectual conflicts of interest? And if this research is being funded, what are the affiliations, if any, of the researchers to the funding organizations? Social value. The researcher has to say who the beneficiaries of this research are going to be and what benefit they gain. And they also need to demonstrate how results will be disseminated, because that is ultimately that is the goal of whatever outcome. So dissemination of results. Scientific validity is something that often people tend to forget is an important part of ethics. A lot of money, time, and resources go into research and in the medical field, and you do want to make sure that that's not wasted and it doesn't put people, because research has the potential for some degree of harm to the subject. So we want to make sure that when such research is conducted, it's conducted in a sound manner. So looking at the scientific importance, they need to demonstrate that there is healthcare advancement, there is advancement of knowledge. Have they looked sufficiently at the background and previous literature and the justification for the particular proposal? Because a lot of proposals that come in replication studies, and even if they are replication studies, there may be a justification, but they need to say why they're doing it. The methodology that is proposed should be appropriate to the questions that are being asked. So scientific validity is an important aspect. This is probably one of the most important parts of our protocol checklist, looking at the risks and the benefits to research subjects. Not only what are the risks involved, what are the measures the researchers are taking to mitigate this risk, and the same thing goes for benefits. We look at consent, proxy consent for patients who are unable to get consent, and especially in children, assent is important. So the consent process, has it been followed? Are any incentives or rewards, compensation, reimbursement being given to subjects involved in research? Confidentiality in terms of how the data is protected, how it's stored, who has access to it, how it's destroyed, how anonymization is done. and the rights of the participants to withdraw from research where necessary, who they can contact if they require clarification, and the access to study results and any product that may be beneficial when the research is complete. So these have to be shown. Just a word on the ethics of financial incentives for research participants, because this is something that sometimes crops up and you want to work your way around it. So why do individuals participate in research or subjects? I'm not talking about the researchers, but the research subjects. Altruism is there, true, but there have been studies actually to show most people would probably, be happy to have some sort of gain out of it. So financial incentives, people who propose, or the people who are the proponents of it, say, well, it does boost recruitment, otherwise you have difficulty finding subjects. It also gives a fair share of benefits of research. So it may be medical benefits, it may be monetary benefits, and it's also sometimes a token of appreciation. It covers costs in some instances. Those may not really be looked at as incentives, they are reimbursements. But of course, there are concerns when there is a financial incentive. Is this inducement or coercion? Now, there's probably a subtle difference between coercion is something that we would probably say is by threat. When does inducement become a problem? When it is undue inducement. Now, how do we define undue inducement? Well, that's somewhat subjective. But if it's in excess, or if the inducement is likely to blind proper or compromise judgment and informed decision making, then that becomes undue inducement. On the other hand, we've got to make sure that there is no exploitation. So exploitation would be the other side of the coin, where researchers sometimes pay very, very small or amounts to participants for their expenses and so on. And when there are financial incentives, the other problem is you might have biased enrollment. So who is more likely to partake in research, especially those who may be from a lower socioeconomic class? Because if they think that if there is a financial reward, they are more likely to take up the position of a research subject rather than those. Research may not be generalizable. And then you also have a, what shall I say, a social sort of responsibility issue, where people of lower socioeconomic class have partaking in research, which then ultimately benefits those of all classes. How do you decide an appropriate remuneration? I won't go down that line, but there are various models that have been prescribed. There's a very interesting paper on this, which I have quoted down. So the other things we look at is fair participant selection. The researcher has to justify why they picked a particular population, what the inclusion and exclusion criteria, where vulnerable populations are picked. So these are population or groups of people who are subject to, or maybe even exploited, or who have little decision-making power, like inmates in a prison, children, so on and so forth. If they are going to be used as subjects, there has to be clear justification for it. And the responsibilities of the researcher to provide medical care for the subjects and continuing care have to be clearly laid down where relevant. Foreign funded research has its own issues. We look to see why this is being conducted in Sri Lanka. Does it take into consideration the sensitivities of local practices and customs? And it's important that these results are communicated to the relevant authorities in Sri Lanka and the academic bodies, because sometimes research that is conducted here is then published out of context in other parts of the world. If it's community-based research, clinical trials, they have their own few requirements that we look at. We have the clinical trials subcommittee that actually does part of this job. And importantly, we look at the information checklist and the informed consent forms. They are trilingual, they need to be. Their terminology should be appropriate. That's something that is comprehensible by a layperson. And they should be administered by a person who is not directly responsible for the care of the patient. So a third person, because otherwise, obviously there is the chance of somebody being coerced into research. So those are the important aspects. I'll wrap up finally. So those are the the aspects of or the different components we look at when we assess a proposal for medical research or research involving human subjects. The decision making ultimately is a collective one. Obviously, benefits and risks weighed, and it's not a perfect, by any means, a perfect system. Obviously, there are variations, reviewers. We all have our biases, prejudices, whatever we try to, however neutral one tries to be, and things change based on time, place, or context, rather. Time, place, a person. So that's what I have to say from this side. Thank you. And I'll hand over to you, Chairperson.
Thank you, Professor Sivaganesh, for a very stimulating lecture. I particularly was interested in the points you raised about remuneration. And I think our audience in particular would be very interested in hearing from someone who is outside their own discipline to see how the medical discipline sees the same issues of ethics, where I think the ethics issues are much stronger in a sense than in the case of the arts faculty. But in all, it was a very stimulating presentation, and I thank you. I'd now like to invite Dr. Nimisha to take the floor. Dr. Nimisha Muttiah is a senior lecturer in the Department of Disability Studies at the Faculty of Medicine at the University of California, and she has been an ERC member for the Faculty of Medicine at the University of California. She is a speech therapist by profession, and after completing her PhD in Pennsylvania State University, she worked at the Franciscan Hospital for Children in Boston before returning to before joining the Department of Disability Studies. So she has had a lot of experience working with children with disability, and her present interests are mainly, her research interests are in augmentative and alternative communication, and she's particularly a specialist on autism spectrum disorders and beginning communicators, training and communication partners, and particularly this issue of alternative communication is one of her pet interests. She has multiple publications in this area, including research on the situation in Sri Lanka. So I think she has a lot to share with us about her experiences both in Boston and in Sri Lanka with regard to working with children in the context of research. Thank you, Nimisha. The floor is yours.
Thank you, Professor Amala, for the introduction, and thank you for having me. I thought Professor Sivaganesh's presentation gave really nice insight and a nice kind of foundation for what I'm hoping to share. I have a few slides that I'd like to share. So specifically, I'm going to talk about conducting research with individuals with disabilities. As Prof Amala said, I was on the Ethics Review Committee at the Faculty of Medicine at the University of California. And so some of the things that I'm going to share are from my experience serving as an ERC member, and then as a researcher conducting research with individuals with disabilities. As Prof Sivaganesh said a little while ago, he talked about vulnerable populations, and individuals with disabilities definitely fall within that purview. They are considered a vulnerable population. So I'm going to be fairly brief, and I'm hoping that you'll have questions to discuss. There are various ethical bodies and organizations, and as Dr. Sivaganesh said, there are very specific guidelines or procedures for obtaining consent when you're working with human beings or individuals. And there are specific guidelines when you're working with individuals with disabilities. So most often, if you are working with a child with a disability, it will require you to obtain consent from the parent or the caregiver. And then obtain consent from a person who is responsible for next of kin in the case of an adult with a disability, if in case that person themselves is unable to consent for themselves. So if they're unable to give consent on their own, then the next of kin or somebody who is responsible would give consent. However, it's also really important for you as a researcher or for us as researchers to think about obtaining consent whenever possible from the individual themselves. And if consent is not possible, then at least assent. And I'll talk about kind of the difference between those two. I'll touch on that. So in terms of verbal assent, so ethical bodies and organizations may require you to obtain some kind of assent from the individual who has the disability themselves. If you're working with a child, the age at which you should obtain verbal assent might differ. So when I was doing my PhD at Penn State, the minimum age at which you have to obtain verbal assent was 8 years and above. That seems to be the norm from what I searched in terms of from other places as well. So assent is generally obtained from individuals who are not able to consent legally themselves due to a variety of reasons. It could be that they are not of age or because of not having adequate cognitive capabilities to do that. And so in that case, they would give assent, but you would still need to obtain consent from the parent or from another individual who is responsible for them. Bear with me here. I'm going to share an example of a verbal assent that I have used in the past. This is actually from my research when I was doing my PhD. And my study involved working with both children as well as adolescents who had disabilities. And so this was the verbal assent that I read, I verbally said to the individuals who are in my study. So it went something like this. This was the same verbal assent that I used for children who are between the ages of 8 to 13. So hi, my name is Nimisha. I'm doing some research with school-age children who need help talking. I want to see how you communicate with your teachers. I will come back often to spend time with you. I will also be videotaping you talking to your teacher. I will keep these videotapes in a locked room, and only my team and I will be able to look at these videotapes. If you don't want to be in the study, just tell me, is that okay with you? So it went something along these lines. And like I said, in addition to this type of a verbal assent, I also needed to get consent from the child's parent or caregiver. So this is an example of a verbal assent that I have used. Let's get back. Okay, so there are some issues with this kind of research involving individuals with disabilities, specifically in a country like ours. So currently we don't have any national guidelines or practices that are followed regarding ethical practice when conducting research with individuals with disabilities. So many local ethical bodies also don't have their own practices. So for example, when I was serving on the ERC at the medical faculty at the University of Kelaniya, we didn't have a specific set of guidelines or procedures that should be implemented when conducting research with individuals with disabilities. Even this verbal assent is something that's not generally included, at least in the ERC that I served, but it was something that was required from the university that I was doing my PhD at. So I have a few strategies or tips that I want you to think about or take away from this if you are planning to work with individuals with disabilities or conduct research with them. So think about how you can make consent forms accessible Particularly in the case of if you're working with adults with disabilities, think about how best to make your consent forms as accessible and as user-friendly as possible. So I'm going to share an example of this. My colleague, Dr. Dinusha Atapattu, who generally works with individuals, older individuals, adults with disabilities, very kindly shared some examples of consent forms that she has used in the past. She generally works with adults who have had strokes or some other acquired disability that has then impacted their communication, so later in life. And so here's an example of a consent form that she has used with some of the adult individuals who have participated in her research. So you can see the pictures to kind of, and it's very simple in terms of thinking about how to make your verbal assent as accessible as possible for children to understand. So keeping the language in the assent form really simple and at a level that a child would be able to follow and understand. Accessibility of consent forms specific to that particular population that you'll be working with. For example, if it's individuals who are blind, then providing consent forms in Braille so that they are able to follow along. Or if you're working with individuals who have a hearing impairment or who are deaf and who sign or who use sign language, then thinking about using people like sign language interpreters to help them to understand the information sheet or consent forms. So thinking about that's your specific population and how you can make that consent process more accessible and easier for them to understand. Yeah, so that's all I had. Any thoughts or questions we can discuss at the end.
Thank you, Dr. Nimisha. Thank you for a thought-provoking presentation, because it's a very challenging area that you research on. And it is very important, the point you made, that we don't have SOPs specifically to deal with people with disability. Since there is so much research that needs to be done in this area, maybe not a lot is happening right now, but there's so much need for research that I think this is a very important pathway we should be taking to think about SOPs for special groups. Yeah. So we come to the last speaker for today, and that's Dr. Kaushalya Perera. So we've gone from the medical faculty to having someone from the University of California, and we are now back with someone from our own faculty. Dr. Kaushalya Perera is a senior lecturer at the Department of English at the University of California and Director of Postgraduate Studies of the Faculty of Arts. And as I mentioned earlier, she's also the secretary of our ERC. She has been serving on the ERC for quite some time. And before joining the Department of English, she has worked at the Department of English Language Teaching at the University of California. And she received her PhD from the Pennsylvania State University and has published on qualitative methodology as well as discourse on higher education in Sri Lanka. And her area, as I understand, will be talking about the challenges of doing research with students, and particularly this issue of there being a captive population. So over to you, Dr. Kaushalya.
Thank you, Professor Amala. I am really fortunate that the two speakers before me have already touched, or not touched, actually spoken a lot about the things that I will talk about. So therefore, there is more context to what I'm going to talk about. So as Professor Amala said, I will talk about researching students, and I'll start with, I know we all know who a student is, but I just want to also talk about aspects that may not be very clear when we think of a student, because we in our minds have a particular kind of student. So a student is someone who's enrolled in a program that's meant to educate, that may be formal, in a preschool, university, Pirivena, tuition class, companies, because companies have courses where students are enrolled, or they want their employees to be educated about things. It may be an informal setting where the teaching arrangements are between friends or colleagues, or there is some unofficial mentoring. The teaching may be happening as paid or unpaid work. The teacher may be officially on staff or a volunteer. Students may be children or adults. as in the cases that Dr. Muttiah spoke about. So there are a number of ways in which a person can be classified as a student or categorized as a student and may then therefore become a participant. When we talk about students as participants, students are sometimes necessary participants in studies on teaching practice or learning or teaching methods or classroom situations. There are a number of instances when we do need to take students as participants. But students are many times convenient participants, and this is one of the reasons why we are talking about students here today, because there are a number of times when I personally and colleagues in most departments where there is some kind of teaching related practice happening, we will see students, novice researchers, sometimes colleagues trying to use students or needing to use students. But they're not always necessary. Sometimes they're chosen because they're convenient. Ferguson et al. Says that captive participants are deemed to be those individuals who are in dependent or restricted relationships with the researcher, such that their ability to consent voluntarily is compromised or limited by their vulnerability to the power of the researcher. So this may be students that you currently teach, examine, mentor, or you know that you have to do teaching, examining, mentoring for in the near future, or you have some kind of authority over them directly. So for example, students who are in my own department of study are captive participants for my studies. And there are a number of issues that happen or with this because of the fact that I have more power, they have less power, and there is vulnerability that is perceived as much as actual vulnerability. So student participants may worry about a number of things. They may worry that their future in the class is jeopardized if they don't participate or don't say things that are pleasing to the researcher. They may worry about their grades. They can worry about their future relationship with the researcher, because I want us to also keep in mind that a student, oftentimes our relationship doesn't end when they stop being our student. Sometimes later on they need recommendation letters, etc., or you may refer to them various jobs or refer other people to them. So they may worry about that relationship. They may also feel that initially they gave consent and they are now unable to withdraw, because after all, I am their teacher. They may also worry about anonymity and confidentiality, because if you are researching the same institution that you are part of and they are part of, they may worry, rightly so, that whatever they say may be divulged to others, or others may just accidentally find out. So there are a number of things that student participants may worry about, especially if you're part of the same institution. So these matters are exacerbated if the researcher is their teacher or a teacher in the same setting. And the power imbalance means that researchers need to take extra care and not take informed consent for granted. Oftentimes, we are told in a research proposal or something that, oh, I gave the letter of consent and they signed. But signing the consent form doesn't mean that consent is willingly given. They may have felt, and I've seen this especially in Sri Lanka, where students feel obliged to do things for their teachers or a teacher in the institution, that they have to participate. So before I go on to strategies, I want to highlight some of the common mistakes that we've seen. One is that of course, you choose your own students because it's easy to collect data. It's there, as we said before, captive pool of participants. Sometimes people think that If you ask students to volunteer for an additional class, you're not taking them from the same class, but you say, okay, if you volunteer for this class, I will teach an additional class. And in that additional class, you may volunteer for it if you want to participate. And then I will teach X number of hours more, and that is I will collect data. So it's unethical because you're supposed to teach a body of students, but at the same time, for your research, you have asked people to participate in a different class. So your students may be taught more by you, and some students who are not being participants of your research may not get that same amount of teaching. There are also issues of providing rewards or bonus marks for participation in the study. Professor Sivaganesh already spoke about remuneration, but this is a different kind of remuneration. Sometimes it's also perceived. Students may believe that even if you say you won't get anything, students may perceive that because they have pleased you, they may, that you may be well disposed towards them. Sometimes researchers may imply accidentally or by intention that whatever that they're doing as part of this may be good for their own learning. So if it's a series of tests that they're taking, for example, you study for those tests, so therefore it may be anyway good because you learn more. Sometimes researchers have already material with them, especially if you're teachers, you have a large amount of material that are your students, and these can be answer scripts that they have written as assignments for you. They may be social media chats that they have had conversations with you. And at some point, sometimes novice researchers saying, oh, I can use that because I already have their assignments with me and I don't have to collect additional data. This is not your data. This is tests that you have given your students. This is these are conversations that you may have had with your students, but they are not your data because they have not given consent for it to be part of your research. They have only consented to be your students. So these are some of the common things. An additional thing that we have seen sometimes is that researchers think that when you get permission from the class, if it's another class, a class teacher, that you can then go ahead and give a survey or give a test to the students. But those students may not have consented individually for that study. They have not given assent, but the institution may have given permission, and they are not the same. So I have a few questions that I think we can ask when deciding on whether we need students as participants. And the first, of course, is, does this study really need student participants? Is there a different way to research this question that you're trying to investigate? And the next is, does the researcher really need to have their own students as participants? And if so, why? There are, of course, instances where you do inevitably research your own students. For example, if you're doing an action research or if you're doing reflective practice or an autoethnography, but you don't necessarily always need to have your own students, even when you need to have students as participants. And if you don't need to have your own students, but you do need to have students as participants, what are other student groups that the researcher can approach? Can you approach another department? Can I, if I want to have students, can I ask for student participants from another department, another institution? And so these are questions to ask yourself or to ask your mentor, mentee, or supervisee as well. So strategies used when students are participants, I would say, unless really necessary, avoid students who are in dependent relationships with you, and to remind ourselves, those are students that you are already teaching or will examine or you have direct authority over. obtain approval from an ethics review committee as much as possible. And I don't mean this in the sense that that will cover you, whatever you do. I mean that then it can be a process of getting reflective questions that you may not have thought of, on getting feedback on your research proposal, on your methodology. So that is oftentimes really a useful thing to do, because here is a set of senior researchers in your field who will give you feedback. So even if you don't have an ethics review committee in your own institution, there are now a number of ethics review committees in the country, in universities, we ourselves, and I'm sure the other two ethics review committees that the other speakers are part of also get ethics review approval applications from different places as well. Ask for consent from students in addition to any institutional permission. Involve others if possible as proxies or assistants. And what do I mean by this? I mean that, and this is something that both Professor Sivaganesh and Dr. Muttiah spoke about as well, or referred to. You can get somebody else going and get consent on your behalf. Sometimes it's very hard for a student to say no or not to take the survey if it is your own teacher asking you. But if it's somebody else, even if it's on your own behalf, that may be easier for the student. If it's a survey or a test, you can ask somebody else to give it and take it. This may not work for interviews. For online surveys, don't collect email addresses. That's a setting that you can unclick, and you can explicitly say that it won't collect email addresses, because that's we may think that we don't collect names, but your email address will give it away. So also sometimes, if this is possible and you are not a student yourself as a postgraduate student or something, you can get an assistant to anonymize the data before you use it. That's also possible, if that's possible. At the end of the data collection process, you can also ask again if there are students who want to withdraw from the study. So these are just a few suggestions. Now, of course, what this means is that your data collection process gets more and more difficult and complicated. But at the same time, I also want to say that this is only a problem if you just decided to use your own students because they're convenient. Otherwise, you would anyway be going through these ethical procedures. I also want to talk a little bit about methodological implications. If, for example, the student participant is chosen because they're convenient or they're captive and not because they suit the requirements of the study, your data may actually not be appropriate for the study that you're doing. There may also be a conflict of interest between your role as the researcher and a teacher educator. You may have to make difficult choices because you may worry about, okay, if I cancel class today because students can't, half the students are not there, will that compromise my data collection? There are other worries may impact your own pedagogical practice. Social desirability bias, it may mean that your data includes false information. If the students feel that they may that they can please you by saying certain things, or you may be displaced by saying certain other things, they may not give you exactly what they think. I'm going to give you an example that I observed as a very new teacher. About 20 years ago, this was a study that was done as a survey, pen and paper. It was collected during the orientation program of for the first year undergraduates in the university I was teaching in at the time. And the reason that it stayed with me was because the study was on sexual behavior. I can't quite remember whether it was about young people or students, but it was given to the orientation program, which, as you know, is just even before you come into the university. And the classroom looked a little like this. Now, This is obviously not the same classroom. This is just a stock photo, but the layout was like this. And I remember being the class teacher where the study was conducted. It was conducted by a different faculty. And thinking at the time, this data is collected in a full classroom on sexual behavior. And first of all, everyone near each student can see what they're going to write. So will they actually write anything that is of use? And whatever they write, will that even be actually what they do? So this is what I mean by your study. If you do it because it's convenient, it may not actually be giving you the kind of data that you need. Here's another example. This is a study on language learning and anxiety. This was also a survey. So data was collected on students from the researcher's own department. But the problem here is that language learning anxiety is sometimes associated with institutional issues. There may be already the students' own issues with learning a language, but it may also be because they don't like the teacher or they're worried about grades, which may be, the rigidness of the institution, etc. So the given answers then can change your perception of the student as well if you're their teacher. So there were a few alternatives that the researcher discussed with me, which is, can she invite students from another institution to do this language learning anxiety study, or if possible, distribute the questionnaire online? Because sometimes we always do this, right? We ourselves, you get a survey in your inbox and you can decide whether to answer it or not. You don't have to have a direct engagement to say no or yes. So just two examples and a few more methodological thoughts after which I will end. One is that your own students are necessary only in a few instances. Like I said before, you can also make do with good enough data. This is Sal Consoli, who works on action research, talks about making do with good enough data, because you want to make sure that your classroom is gets more priority than your research, even if it is your own research. There are also instances more and more where participatory research is conducted, where the participants, the students, are also involved in the planning and implementing of the study. This may of course be difficult for postgraduate and undergraduate students because of institutional constraints, because we expect most times for the student to be able to do the study by themselves so that they can then therefore experience and prove that they are a full-blown researcher at the end of it. But who knows, maybe the institution will be open-minded. For researchers who are not students, this now also includes co-writing, and I think it can be a really exciting way to do a study if you're not bound by constraints of having to prove that you can do a study yourself, etc. So these are my resources. These are 3 really good articles that you can find on Google Scholar, on Sal Consoli's on good enough research, on how he himself made decisions. So there are examples. Ferguson, Young and Mirick's article is also a really good article that I use with student researchers who want to use other students as participants. And of course, on participatory research, where children designed the research and wrote it, Maynard et al. Is quite good. Thank you very much. Prof Amala, over to you.
Thank you, Dr. Kaushalya. I think I should remind people that the recordings, including the slides, will be available online. So anyone who's interested in those references can actually go back to them. And thank you very much, Dr. Kaushalya, for opening our eyes to many issues related with doing student research. I think I was, interested in the problem and wondering what would happen if you put an open call for any student from anywhere to come and do your study, and also the issue of what you meant by autoethnographies. And I hope you will use the question and answer time to answer my questions on your presentation, which I enjoyed. It was very clear and very informative, and a good warning to all of us who often think that it would be good to do research with our own students. Sometimes it's because they are the ones who understand issues. So, for example, if I using economic students, I mean, sometimes it's good to talk to economic, get information from economic students because they think the same way, and they will be able to answer questions which maybe the people in other departments won't know if you ask them about an issue like opportunity cost or cost benefit analysis. We would, you find easy to use students because they are fluent with the area that you are interested in. But I think you've given us some solutions as well as the problems that will come if we use our own students. So thank you very much, Dr. Kaushi. And now let me open up the discussion to the others who are listening in. And please, if you can, just give us your name and designation and then ask your question. And keep your question brief. If you want one particular speaker to answer it, please mention who that is, or otherwise they will all answer according to what the area of the question is. Thank you. Yeah, I see Dr. Murali Valipura's hand up. Can you go ahead, Murali? Yeah. Murali, go ahead, unmute and ask your question.
Yeah, thank you. I actually don't have a question. I have a few comments on this.
Yeah, sure. Go ahead.
It is very interesting to have this discussion. All the talks were very good, excellent. My point is that the vulnerable population, that who is the vulnerable population? If we go to the debate in the during the Second World War, these Nuremberg trials, any population where they are not aware of giving consent and without the knowledge could be considered as vulnerable population, and they were compelled to undergo those experiments. So the same principle applies if we take in Sri Lanka. Say, for example, now the DHS survey, we are taking blood samples and surveying for anemia. So there is no consent, right? So that's the innocent population without knowledge that there should be a consent for this kind of testings. That become the vulnerable population. So that in the ethics, we are normally talk about vulnerable population. We define certain people as vulnerable population. But I would say that in the context where we see in the Sri Lanka, now even after COVID, I will come to that example. Now we see that any population who are not aware of this consent procedure and don't have enough knowledge to demand for the ethical protocol to be followed can be considered as vulnerable population. That's one aspect. Other aspect is, I would say that the COVID exposed the ethical issues that despite all these guidelines, what Professor Sivaganesh was telling, that we have been following all these protocols, have opened up the vulnerability. Now we starting with this, the Dhammikapani, and then the breathing exercises, and then the Western medicine also. There are drugs, azithromycin, hydroxychloroquine, and ivermectin. All have been used without any known benefit. So that despite all these ethical protocols, that we have failed to stop these unethical practices where there is no evidence. And in fact, the Dhammikapani, there was billions of money was spent on that. And there is another school of thought, whether the ethical protocol has prevented the real experiments. If we go to the most successful vaccine in the world, that is the smallpox vaccine. So if you remember the history, that Edward Jenner was experimenting cowpox germs, injecting cowpox germs to the population. And then that resulted in the discovery that it prevented the smallpox, and we successfully eradicated the smallpox. But I wonder whether any of the ethical committee would approve if a present day doctor applies for a study injecting a virus similar to cowpox to the humans to prevent another disease. Thank you.
Professor Sivaganesh, would you like to take that question because it's mainly medical?
I think that's a very important point, Dr. Valipuran. First, you were talking about, if I may start about in the context of COVID-19, what you find today in terms of vaccine acceptability in the US, for instance, it's primarily the reluctance to take vaccines. Of course, there are various groups, is predominantly seen among the African American and the minority communities. And one of the reasons for this is they perceive, in fact, it's been mentioned that it's in direct relation to the Tuskegee syphilis study, where African American males, as I told you, were followed up for 40 years. And there is that kind of breach of ethics, especially when it comes to light, discredits systems and the credibility of subsequent, even well-conducted studies are, brought are questioned. So bad ethical practices have consequences for a very, very long time. In terms of, I can't agree more with you on the fact that historically a lot of advancements in medicine have come about by probably crude and practices that will not be admissible today. What you said was a very important example. I think Cotton Mather, he actually inoculated his slaves with the virus in smallpox. And then if you took even treatments of scurvy, in gonorrhea, there's a whole list of these things. That was in an era, I'm not saying it was excusable, but then there were no checks and balances in place. As I said, ethical approval and what is acceptable is contextual in terms of time, place, and person. That will not be acceptable today, but there are alternatives. As ethics review committees, that is the burden the members need or take, or that is the responsibility we need to take. We need to not be obstructionists. We need to look at, so the risk versus benefit is there for us to consider. And at every point, we need to look at the risk to the individual, but we need to balance it against the benefits, not just at an individual level, but at a societal level. But yet for all, we've evolved, and we need to we can't put the individual at a significant risk for the, in the name of advancement of medicine or knowledge in that sense. So there are lots of checks and balances in place, but we are all, we are conscious of the fact that the researcher wants to answer a question out there. Of course, it's all about motives. Sometimes research is for the sake of research. So that's where they've got to actually really justify, if they're going to take some amount of risk, they need to justify why they're doing that experiment or that particular study, how it's relevant, and what the outcomes are likely, or how the outcomes are likely to determine how things move forward. So obviously there's no perfect system. And that's where ethics research or ERCs are there. It's a collective decision of people looking at this from all perspectives.
Thank you, Professor Sivaganesh. And also, Dr. Murali, I think I was wondering whether, the DHS blood drawing for anemia, that's a surveillance technique, and also the Dhammikapaniya was behavioral. I don't think it was considered a research in that sense. It was, people were taken down the wrong line. I agree with you on that, and that there was, behaviorally, there was, it was not ethical what was happening, but I'm not sure we can really group that under research ethics. So that's another issue I want to bring up. Anyone else with questions?
Hi, Professor. I have a question. I'm Lavanya.
Yeah, go ahead, Lavanya, and Dushi after that. Yeah, Lavanya, go ahead.
My question is, I think Dr. Nimishi, the question is for her. I actually have a question regarding assenting. So when it comes to assenting, so now when it comes to consent, we have a form, and then the participant and the researchers are signing, and we're giving a copy to the participant as well. So when it comes to assenting, can we audio record the thing and give a copy to the participants' parents, or consent, because still we are getting the consent of the parents? So will that be sufficient? How can that happen? Can I have a brief explanation or something regarding assenting?
Yeah, thanks for your question. So previously in the past, how I've done it is, so in addition to getting the verbal assent, there's always the consent, because the verbal assent is not enough, really, from a legal standpoint, and also from a procedural standpoint, from an ethical procedural standpoint, it's not enough for the individual to participate in the research. So the consent form is actually what really needs to get signed by the parent. And so the verbal assent is for either the child or possibly the individual with a disability whom you may not be able to get consent from in that sense. So yes, you can record it. In the past, like even the form that I shared, so I verbally said it, and then I had a witness sign that it was done. Does that make sense?
Yes, thank you very much. Yes, thank you.
Dr. Nimisha, would you have the parents with you when you get the assent from the child, or a responsible adult with you if it's a person who is not able to answer for themselves, where you're not sure of their cognition? Would you have another adult present when you're getting the verbal assent?
Yeah, so for the study that I showed the example consent form for, what happened is it was conducted at the child's school. So initially I obtained consent from the parent first, and if the parent agreed for the child to be in the study, it was then that I got verbal assent from the child. And because it was conducted at the school, it wasn't always possible for the parent to be there. So then...
Yeah, thank you, Dr. Nimisha. Yeah, Dushi, I think you have your hand up. Do you have a question?
Yes, Amala, thank you. And also, may I quickly say thank you to all three speakers today for really excellent presentations. My question is actually addressed to both Professor Sivaganesh and Dr. Muttiah, because it's a conversation that we have had in the Arts Faculty Ethics Review Committee, and it's about monitoring and following up. And I know that Professor Sivaganesh said that that's a little bit of a weak aspect in their committee as well. We really don't know how to do this. So we approve a research protocol, but then after that, we don't know whether the researcher is following it or not. And we really don't have any punitive measures in place. So we are not sure how to go about it. May I have your any suggestions from the two of you?
Good question. I really don't have the answers. I don't know, Nimisha might have some. I think all ethics committees and processes evolve. So in that process of evolution, I think we've now reached a stage where we are quite robust in our assessment of protocols. I think the next stage would be to actually, as you said, enforce things like monitoring, getting reports back. To be very frank with you, we don't have the capacity or the infrastructure to really do that. If you think of the number of protocols that we go through on a monthly basis. So practically speaking, it is a very important thing, because otherwise it just becomes, you know, something on paper, but we really don't know what's going on out there. The only probably, well, I don't know whether to call it consolation, but is that a lot of research that is done in this country, thankfully yet, is not something, at least from the medical point of view, is not something that has, at least from what we see, they don't have huge ethical concerns in terms of risk to patients. A lot of them are very, very low risk in that sense. In fact, to be very frank, a lot of the proposals that we go through, we end up actually doing more of a scientific review in terms of methodology. The people who submit it get good peer review for their proposals. And I think it does a lot in terms of, we do a lot of methodology, scientific validity, and so on. And we find most of them, you know, the ethically kind of the risk to patients are low risk. But yes, so because even in terms of science and research in this country, from the medical side, we haven't gone into major randomized control trials where we are doing big interventions that are, you know, potentially dangerous, or so that hasn't. But if and when we reach that stage, we will need to have something in place. I just presume that this will evolve as we go along. Nimisha, yes.
Yeah, so I agree. I agree with what Dr. Sivaganesh said. I mean, part of our ERC requires that at the end of the project, the primary investigator submits a report. I think yours probably says something similar.
Yeah.
But yeah, as you said, I think there's no monitoring of whether that is submitted or any follow-up beyond that. But however, with things like clinical trials, primary investigators and whoever the investigators who are involved in the studies are required to report at certain time periods. There are follow-ups that happen. They have to report any adverse events that have occurred, and then there's monitoring of that and following up, and the primary or the researchers have to report what actions they're going to take to prevent that in the future, etc. So with clinical trials, it's much more rigorous. But with the regular studies, yeah, that's a problem.
We also have the clinical trials as a clinical trials subcommittee, which actually bears the brunt of. So they are much, they deal with the clinical trials, and as Nimisha was saying, looking at how things are progressing, adverse events, and so on. So they really take that task over from us where clinical trials are concerned.
But that level of monitoring is not done for it. I mean, or even following up about the report that should have been submitted. Yeah, it's not done like that.
Okay,
can
thank
I just
you.
ask a question?
Yeah, go ahead.
Can I just ask a connected question whether the medical faculty, University of Colombo and the one University of California, whether you have the practice of giving the ERC members connection, number on the information sheet where people can complain to you if there are problems, and whether they also practice the fact that if you don't give the progress report of one study, you're not going to get the, ethics clearance for your next study. Are those commonly used? I know SLMA uses them, but I'm just wondering.
For us at Kaushalya, we do. It is a requirement that the ERC contact information is in the consent form. The second aspect of what you asked about not getting approval for a second study if you haven't submitted your progress report, that's not happening.
Yeah, it's the same for us. We're not that punitive yet. As for the contact details, were you asking about the researchers for clarification? Or the ERC?
Yeah.
Yeah, the ERC.
I think that's good.
Yeah,
so
I think that's really good.
If people can complain that things are not being done properly,
right?
Yeah,
they can speak to the ERC.
But
because
so the reality is, our populations our subjects are generally very passive unless there is what shall I say, a major breach. I doubt very much somebody will come up. It's like our consumers in this country. So
Thank you. My question actually was stemming from, we don't get that many protocols to do with medical research for obvious reasons, but my question was stemming from, protocols that we get where people are working with sex workers or with prison inmates. And I was thinking more along the lines of causing undue stress, more mental harm than physical harm, and how to avoid that happening when a researcher is even asking questions, the proper way of asking a question, which we are very, very careful to tell them how to do, but then who knows how it happens out in the field. But thank you very much. I really like the idea of having our contact details on the consent form, because we also say that a copy of the consent form should be given to the participants. Whether that happens or not, we don't know, but at least that's something we say they should do. So if a participant has that consent form with them at any point, then if they feel like it, they can get in touch with us. So I think that would be something that we would like to institute. Dr. Perera is the secretary of the committee, and I'm sure she would agree with me. So thank you very much for that idea. Thank you.
Any other questions? Yeah, Tanini, you have your hand up. Can you go ahead?
Yeah, thank you, Prof Amala. So for those who don't know me, I'm from the Department of Sociology, Faculty of Arts. My question is, thank you very much for all three speakers. It was a very interesting and stimulating presentations. But something that didn't kind of reflect on any of the presentations on my end, and specifically being an anthropologist by training, is that the discourse of ethics and culture. Like, yes, we did speak about context, but now there was no reflection on how ethics actually reflect on culture or the connection between the two. So I was wondering whether that should be part of the discussion, or what your opinion of that would be. That's my first question. And secondly, this is following up on something that Professor Sivaganesh mentioned about clinical trials. I was wondering whether, though you said that there aren't any risk trials happening in Sri Lanka at the moment or in its history, I was wondering whether you remember the suicide-related study that was done by Michael Edelstein some time ago, and how that kind of created a lot of waves in the Sri Lankan medical context, and that researcher was actually banned from doing further research in Sri Lanka. So is it that we are not aware of these things, or is it that we are not giving them enough consideration? Those are my two questions. Thank you.
Yeah, thanks. Thank you, Tani, for that question. I'll answer the second one first. I think when Michael Edelstein did his work, that was probably somewhere in the early 2000s. Correct me if I'm wrong. I'm not exactly sure when that was. We probably didn't have all the, so if you took the, if I'm right, the Colombo ethics, the Colombo ERC got its accreditation somewhere in 2009, if I'm right. And as I said, the processes have been evolving, and more SOPs and checks and balances have come into place. And I really don't know the details of the Edelstein, but I do remember there was an uproar or a bit of a hullabaloo about that. I'm not very sure about the details, but it was in an era where probably these protocols were not well established. I don't by any means mean to imply that there is nothing harmful that can or is may, or there is no potential for clinical trials that can be harmful that in our country. Yes, I'm sure they can. I'm talking in general compared to, and I'm talking relative to the kind of trials that occur on a fairly routine basis in in the so-called Western world, where many more interventional forms of clinical trials take place. So in that context, it's much less. So it does not by any means absolve us from the need to actually monitor what is going on. That was not the implication. I'm just saying, I was just trying to say that we are probably lucky that there aren't many such interventional trials going on. But like you said, it is coming there. So as we go along, there will be more and more trials, and that's why we need to enforce that. With relation to the first question, again, and what I meant is when we talk about the composition of ethics committees, if you took I can't speak for other ethics committees, but if you took the Faculty of Medicine Ethics Committee, we had a very diverse group, but I'm not very sure whether that diversity whether diversity is synonymous with representativeness. And what I mean by representativeness is whether all socio-cultural sensitivities, or I'm not a sociologist, I don't know whether I'm making myself understood. Those variations or sensitivities are understood by people who sit in those ethics committees. We are seated there actually making decisions on what we perceive somebody might find unacceptable or acceptable or troubling and so on. But a large number of our subjects in medical studies, a large number of them and our patients who come to public hospitals are patients who are from a low socioeconomic group. So I really don't, I'm sure you're right. We probably are not diverse or representative in that context. So we may, and there's always the danger that a lot of us, we carry over some of these ideas or concepts or of what we think should be done or is acceptable or the norm from our experiences in research, ethics, and so on from, what shall I say, the Western world, which may not really be the most important priorities in the minds of our people. So I don't know, it's debatable. I would like to hear what the others think about that.
Thank you, Professor Sivaganesh. And I think you've got your hand up, Kaushalya. Kaushalya, have you got your hand up? Yeah, go ahead, Kaushalya.
Amala. I'm glad that Prof Sivaganesh brought up this issue of representation versus diversity for the second time, because when you said it in the presentation, I was quite intrigued by it. And I wondered if you know of or could suggest, well, more than suggest, like, do you know of other ways in which ethics review committees can be more representative? Are there instances, or I mean, not to say that if there isn't, we shouldn't do it, but I'm curious to know if there's something that we can work towards. And sorry, I should say that this question goes to Dr. Muttiah also.
Good question. I stuck my neck out there, so I think I have to try to find an answer for that. I really don't. It's something I think we need to think about. You see, membership in an ethics review committee. It's how shall I put it? It's a group of people who generally come from fairly common origins. When I say common origins, I'm talking in terms of academic circles, friends, you know. I don't want to sound flippant and say like, you know, a club or sorts, but you know what I mean. I think it's something we need to think about how, because it is important, because we are looking at things through our prism, which is not necessarily what a vast majority of our population maybe cares about. And then we sometimes obstruct research on the basis of what we think is the norm. And we may be just representative of a certain strata of society at a particular level. So I'm sure you all know, you all are better suited at talking about that rather than me. I'm a very clinical fellow, so I'm not sure what Nimisha has to say. Yes.
Nimisha,
Yeah,
would you like?
Coming back to the question that was asked by Tarindi, I think, right, about the cultural aspect. So I think in particular, if you're doing research on a topic like disability in a country like ours, where there is so much stigma associated with it, with having a child with a disability, with having a disability yourself, there is a lot of stigma, right? So it is a very sensitive topic. And I'm glad that you asked about that, because I think, both from an ethical review committee standpoint, and also, I don't know, as researchers, I think we have to be really aware. I don't know, unless society becomes more aware about disability and more accepting, which as we're moving into more topics like inclusive education and inclusive societies, hopefully that will happen in the future. But this is a very sensitive topic, and it is a sensitive topic to do research on. In terms of the other issue that was brought up about ERC committees being more representative, again, I don't have an easy solution, but I know one thing that we have done in the past when I have served on the ERCs, say, for example, we get a proposal, and this is different to the topic we're talking about, but say for example, we get a proposal on a topic that the current committee does not feel like they have the expertise on to make a call or to make a judgment call. We have got outside reviewers to come in and review along with somebody internal. And so maybe it is also thinking about that in terms of any proposals that come in that could be, I don't know, that if you feel like you're not really, you don't have the expertise, or you don't feel like you have the representation to make a judgment call on. I know we've done it in the past, but not in this aspect per se, but it's more like there's no one currently on the ERC that has this subject expertise.
Yes, that we too have done, where we've got a proposal where we know very little about, and this, yeah, we've done that, but probably that can be extended to even, if you're looking at some aspect of, I don't know, social cultural acceptance or something.
Thank you both. It's something that really interests me, and as I read more and more about participatory research and what really participatory research means, and what can that be always a good thing or not. So been reading a little bit more in that area, and so therefore when the two of you were speaking, I was thinking of that as well. To Tarindi's question, actually culture is a really it's really actually a problem area when we talk about student research, because students oftentimes don't say anything because we are so used to saying yes to teachers, or even when somebody tells you do this, if you're a teacher or somebody in authority, we do that. As Prof Sivaganesh said, our research participants are usually very passive, and students more than anyone else, I find. So it is an issue, and I do, when we talk to potential researchers who may be using students, it's something that I at least talk about, and I know a few other research methodology lecturers also do that.
Yeah, can I come in with the objective of having a sort of diverse group in the ERC? I know that certain research committees have tried to get people like teachers or principals, housewives, journalists onto the panels, but very often one of the issues is that we often do these things in English, and then I don't know how representative the people we are getting onto the panels are. For some time, I was actually the layperson on SLMA till they had a they had a evaluation, and then they were told that I was not a layperson. So I went from being a layperson to a sociologist. So but they do have now some journalists, and but all of us are English speaking, so, and westernized, as Professor Sivaganesh mentioned. So in order to make it a really representative ERC, it becomes very challenging, particularly where language is concerned. But I think one option is to get, be culturally sensitive. And if there's any study where we feel we don't know to understand the study, that we do go ahead and get some advice from anthropologists or sociologists like that. Yeah. So Kaushalya, I think we've had a very interesting session and come to the end of our time. Any other questions that are crucial that you want to really get an answer for now? Otherwise, let me thank the panel. Let me thank Professor Sivaganesh. Let me thank Dr. Nimisha Muttiah and Kaushi. And I think we have gained a lot from having this session. It's opened our eyes to a lot of issues that we need to contextualize in the context of our own ERC. So we look forward to you being part of a panel with us in the future. But for today, I will thank all three of you and thank all the participants. And I will say good evening, good night to all of you.
Thank you.
Thank you for having me. Thank you.
Thank you for.
Thank you, everybody.
Thank you. Thank you, everyone.